All right. Good morning and good evening, everyone. Thank you for attending the fourth webinar in this series today. And I'd just like to say, thank you everyone for attending. This lecture is proudly presented to you by the Cyber Patients Expert Series with the goal of connecting students in healthcare to medical practitioners throughout the world. And as you know, our lecturer for the series is Dr. Alberto Ferreres. Don't forget, if you're a premium Cyber Patient subscriber, you have access to over 120 cases. And then if you are not, you still have access to 10 cases, including 3 COVID-19 related cases. So, please feel free to access these cases and attempt some of them and progress your skills. And I'm just going to post, if you have any questions, please feel free to email us here. And without further ado, let's jump right into it. Dr. Ferreres, please take it away. Thank you so much.
Perfect. Good morning, good afternoon to all the audience. I've seen people who are from Tbilisi, Georgia. I'm here speaking to you and connected to the web from Buenos Aires, Argentina, the capital city of Argentina in South America. And it's a pleasure for me. And I welcome James Wells and all the leadership of Cyber Patient for allowing me to interact with all this group of highly focused and highly committed audience and most of you medical students and future colleagues. So a tip at the end, in the last slide, you're going to see my email address. Please feel free to reach me with whatever doubt, comment, or need or request for everything that you need. I will be more than happy to interact with you. And this is one of the useful aids which provides this virtuality. So go ahead and request me as you need. So the system is the same. We're going to leave Q&A for at the end of the lecture. And the topic we are going to address today is the informed consent in medical practice, which is of paramount importance. And we are going to see the difference between providing pharmacological indication, which is at the end of the day just a pill to a person, than to provide the indication and go through the informed consent when you need an operation, and not to mention when you need a huge operation, a complex operation, for example, a malignancy. So I have no disclosures. And this is the structure of my lecture. After a brief introduction, we're going to frame the concept, and we are also going to see what is the practice of the informed consent and some recommendations for you as future colleagues to follow. If we go back to the 5th century before Christ, that means the gold century of the Hellenic civilization in ancient Greece. Plato, one of the most well-known philosophers following Socrates, and Aristotle, wrote in one of his books, The Laws, in the book 11, these comments regarding slaves doctor and free doctors. Remember that at that moment in the Greek cities like Athens or Sparta, there were free people who were the citizens, and there were slaves. And there were physicians or doctors which were absolutely limited, of course, due to the knowledge at that time, who practiced on slaves or on free citizens. And so look at what Plato describes. The slave doctor prescribes what mere experience suggests, as if he had exact knowledge. And when he has given his orders like a tyrant, he rushes off with equal assurance to some other servant who is ill. But the other doctor, who is a free man, and who attends and practices upon free men, carries his inquiries far back and goes into the nature of the disorders. He enters into discourse with the patient and his friends, and is at once getting information from the sick man, and also instructing him as far as he's able. And he will not prescribe for him until he has first convinced him. And so the free citizen had the faculty, the power to decide if he or she were going to follow the doctor's prescriptions. And this should be considered 5 centuries before Christ, the germ, the initial inspiration for the doctrine of the informed consent process in the medical field. But of course, you need to remember that the doctrine of informed consent is a contribution from the law to the medical scenario, and also a contribution of those countries where common law is the legal system, quite different from the French codified rulings. So it's also interesting to go through this quote, as Shaw and Shaw stated in their seminars in anesthesia. The doctrine of the informed consent, like the apocryphal elephant to the blind man, each of whom is feeling a different part, seems to be many different things. And on one side, you have the physician, who considers this doctrine as a bureaucratic legalist to me, the patient who thinks that this is just a form they want me to sign and to relieve me from, and the physician and the team from any guilty, the ethicist, who considers this as a victory for patients' rights, and the judge, who states upon his atrium, this doctrine is what I say it is. So there are different points of view, and many times the one who is harmed during this process is the patient and his relatives, because we are going to see which is the real application and the real world, and the conflict between the theory and the practice of the informed consent, because the equation is that you need to be truthful, but you need to keep hope in the patient and his or her family. And if you are crude and more than realistic and manage statistics, probably the patient will not accept the operation and decide to continue without an operation. And I would also like to introduce this ruling from the Supreme Court of Justice of the state of Louisiana in the case Lacasse versus Collier, who very clearly point out all the difficulties about the doctor-patient relationship and how the patients make decisions in his or her best benefit, and how this decision should be guided by the patient, by the physician. And the ruling states, if all decisions by the patients could be made on an intelligent basis, if all patients had sufficient scientific background and scientific knowledge of the human body, if the decisions of all patients could be sufficiently free of the fear of the unknown, of superstition, and of other extraneous influences upon the decision-making processes, if all patients were able to understand the physician and communicate with him, if the physician were not faced with this and various other impediments, then the doctor-patient accord would be a problem of manageable proportions. So this ruling puts the emphasis on other difficulties which interrupt communication, freestanding communication effective communication, efficient communication between the patient and his or her physician. And of course, as I mentioned, the informed consent process has been a contribution of lawyers and of ethicists, and many times physicians, and specifically surgeons, do not feel that comfortable. And what I recommend that they need to build up their relationship upon trust. And of course, which is the extent of the information they need to provide, and which are the conditions the patient is encountering, because you need to remember that the patient and most patients are vulnerable. They are on the vulnerable status because they are requesting care for the pain. But on the other hand, we need to be very clear that the medical informed consent is ethically, morally, and legally mandated. And why it is mandated? Why it is a must? Because of the fiduciary responsibilities flowing from the patient-physician relationship that is not only built upon a contract from a legal point of view, but also from our concern and altruism to provide the best care and to keep the interests of the patient in first place, and only secondary be worried about our own self-interest. And of course, this informed consent process is surpassed by the ethical principles of beneficence, which means to do what is good, as we have seen previously, and is embodied in the issue of a paternalistic approach. But look, for example, at some of the major drawbacks and breakdowns of the informed consent when you are related to emergency surgery or trauma. If you are receiving at the emergency department a patient who is unconscious or is in such a sick state and compromised that he or she are not able, they are not conscious, they are not able to understand all the risk involved in the operation, they are not able to provide a sound informed consent. And what should you do? Wait? No, you need to proceed. You need to act. You need to work as a physician and provide the best surgical care which is in your hand. And of course, the second principle is that of non-maleficence, which is embodied in the oath, the primum non nocere, and you need to refrain patients from performing harm. And the informed consent process is the crystallization of the principle of respect for patient autonomy. But always we are going to see in real life how much autonomy is able to act a particular patient, and if he or she are not worried with the burdensome of their diagnosis or disease. And of course, it's related to justice, not only with allocation of resources, but many regulations, many countries have different laws highlighting and recognizing in a very express way the rights of the patients. And one of those rights is to a due process of informed consent and to be dutifully informed when an operation is indicated. And why this difference between just a medical informed consent process and a surgical informed consent process? Well, because the risks at stake are quite different, because any operation has, as has been globally demonstrated, 25% chance of complications, so something going wrong, because operations are prone to risks, to complications, to pitfalls, to sequelae, to intraoperative complications, to errors. So there's a lot of things to discuss with the patient. And many times the patient is not able to have a full understanding of all the information that has been disclosed by the surgical team. So let's move to the concept of informed consent. The first highlight has been Slater versus Baker and Stapleton in the British Islands. Baker was a fracture fixer, not to mention he was a doctor, a traumatologist, orthopedist, and Stapleton was a apothecary. And the most important contribution of this ruling is not with the informed consent process, but specifically with the concept of standard of care when judging presumed malpractice from the side of the physician. This gentleman, whose picture you see, who is Judge Benjamin Cardoso, the School of Law of Yeshiva University in New York, in downtown New York, bears his name, was the one in 1914, in this case, Schlöndorff versus Society of New York Hospital, who consolidated the concept from the legal point of view of consent, of therapeutical consent. The lady, Mrs. Schlöndorff, accepted to have an operation and to research her abdomen and pelvic cavity, but she did not allow to be performed an hysterectomy. However, the gynecologist considered that the tumor was spreading from her uterus, and he decided to perform a complete hysterectomy. And that was the reason why the Society of New York Hospital was found guilty, together with the physician, of not respecting the patient wishes. And in that case, Judge Cardoso assimilated an operation without the due informed consent process as a felony, as an illicit, as a big mistake. So remember that any surgical procedure to be considered not a felony needs to be justified. There will be indication based on evidence and on the clinical course, and also the due process of informed consent. So here in 1914, we have the consolidation of the legal concept of consent, but the addition of the information requisite was introduced in 1957. In this case, Sargo versus Leland Stanford Junior University. That's Stanford University. And Mr. Sargo was a man who had a chronic arterial disease in his legs, and he needed to undergo an orthogram, which was absolutely well grounded and indicated, but nobody discussed with him the issue that he could have a complication or neurological impairment of his legs, and that was precisely what happened. And this was not proved through the annotations in the clinical records, so the University of Stanford University was found guilty. But the major contribution of this case in its resolution was the term informed consent was coined and used for the first time. So, according to Merson-Fischoff, the informed consent process includes different steps. The first, when the information is disclosed by a physician to a competent person, and being competent is not the same as being capable. One has to do with competency and the other has to do with capacity. Is different from the psychiatric point of view and from the legal point of view. Second point, that the person understands the information provided, which I would say is not usually the case, or even worse, they might understand the information, but they do not recall the information, and if surveyed, they are going to remember, for example, something such as simple as conversion during a minimally invasive or laparoscopic procedure. And the third issue, the third component, is a decision makes upon free will to accept or refuse the therapy or a surgical procedure that was considered or offered by the team. And the American Cancer Society, and this involves also truthfulness, defines informed consent in their webpage as a process of communication. I like this. This is a process. This is not just a single encounter between the team, the healthcare team, and the patient and his or her relatives. Between you and your healthcare provider, I mentioned that I'm a physician, I'm not a provider, that often leads to agreement or permission for care to provide treatment or provide services. Every patient has the right to get information and ask questions before procedures or treatment. However, we see everyday patients that they will, doctor, I trust you, I don't want further detail that when I need to get admitted to a hospital, when is going the operation to be taking place, do I need some stay in the postoperative course in the intensive care unit, and okay. And if adult patients are mentally able to make their own decisions, medical care cannot begin unless they provide informed consent. So you're not able to act if the patients do not allow you. And of course, you have formal and you have tacit. If you explain and the patients get admitted and the patients consents to be placed on the stretcher and taken to the OR, that's a very clear way that the patient is not refusing the operation, but as accepting the operation. The Gordian knot and the discussion will focus upon which information does the patient perform this act of consenting to be placed on a stretcher and transferred to the OR. That's the Gordian knot. And here in this slide, we see the elements and stages of the informed consent. There are some conditions: competence from the side of the patients, and free will, in the sense that he or she are not forced or subjected to any pressure. The information process includes first disclosure of the condition from the physician, the recommendation the physicians perform upon the clinical situation supported by the evidence and complementary X-ray studies, etc. And third, and very important, the understanding of the patients about his or her condition. And lastly, we have the consent, which includes the decision-making process and making it clearly how the patients communicate this decision that he or she performed, how this decision is documented, and which means at the end of the day, in the authorization to proceed, as very clearly stated by Leclerc from the Netherlands in the World Journal of Surgery in 2010. But do you think that every informed consent form is valid? There are some issues that there are some prerequisites or conditions. It should be a consequence of the free will of the patients, of the information received, and of the capacity of the patient. So we need to stress the fact that it needs to be voluntary, it needs to be informed, otherwise the consent should not be considered valid, and the person needs to be capable, means that he or she understands the information provided and can use that information to make an informed decision, which is quite different from the concept of capacity. If you are an 18-year-old person, the law considers that you have capacity to make your own free decisions on your own health. But of course, there is a burden upon the physicians when you need to assess the patient's ability to understand which are the implications of all the information you are going to provide, the relevancy and importance of the information you provide, and which is the nature and purpose of your potential intervention. And of course, burdens, risk, benefit of all options, including the option of not doing anything at all. So, and the informed consent page form needs to be included in the medical record, of course. Nowadays, there are some aids you can receive recordings, you can receive information through the web page, etc., but not always this is the way we proceed, specifically in many Latin countries in Latin America. So for many, the surgical informed consent, more than a process, is considered as an operative request and a mandatory request and an imposition of the law upon the surgical profession in order to take a patient to the OR. And now we're going to see, because one thing is what we write and what the doctrine says, and another thing is how informed consent is managed in everyday clinical practice. And in that sense, you need three elements important to consider. And one is the awareness regarding the patient, what the patient wants to know and what the patient demands to know regarding his or her disease. Second comes the understanding, which is a consequence of the communication process you undergo with the patient, in which you need to bear the importance, not only of the words, but of the non-verbal and paraverbal communication. And also recognize that the patient is suffering, not only from the disease, but from the burden of suffering. He undergoes fear. He's absolutely vulnerable, as I say. So you may explain plenty of details to this person, and the patient will not recall. I would just say nothing, but maybe he or she forgets, as we are going to see in some papers, some citations I will provide 80% of the information you provide. So trust returns as a very important aspect of the patient-physician relationship. And this is, as Applebaum and Grisho stated in this very nice paper in the New England Journal of Medicine, about the ideal condition. But our patients are not ideal. Take into account the 82 years old lady, maybe she's with pre-dementia or she's in an hospice, and she's overwhelmed by the diagnosis of infrarenal aortic aneurysm. And it has been explained that she needs an open repair because endovascular therapy cannot be provided, the aneurysm is not suitable, and all the risk encompassed with the operation. I fear a lot that this lady is able to fully understand all the issues, and probably she will not understand them. Probably they will impair her deciding capacity. They need to understand the problem, they need to understand the treatment, they need to understand the alternatives, they need to understand what happens if they refuse treatment. They need to appreciate the consequences of refusing or accepting the treatment. And they need to make their decisions not based on delusion or depression. And this, as Applebaum very, very graphically states, this is an ideal world. This is not the real world of surgeons and patients fighting for their oncological disease. All the things you need, they are recommended for you to know before having surgery. Why do I need an operation? Which operation? Other alternatives to surgery. And this comes from the US, so the issue of cost, which are the benefits of having the operations and the risk of having the operations and the benefits of not having the operation. What happens if I do not get the operation, and of course the benefits of having a second opinion, the type of anesthesia, how long it will take to recovery, and of course making sure that the surgery is going to be safe. And this is the recommendations, all the questions you need to pose before an operation. But as I repeat again, maybe you are in a vulnerable state and you are not able, you probably go to Dr. Google in the afternoon or the day after, but many times you are not able, due to the short encounter between the physician and the patients, to forward all these questions that you can see in the slides, these 9 questions that you should forward to your surgical team. Another piece of information, specifically in patients taking care in university hospital or state hospital, who is the one who will perform the operation? Is it going to be the residents? Is it going to be the fellow? Is it going to be the same faculty I saw in my first encounter at the clinic? You need to provide answer to this, and this is a very important subject of information. And of course, many times physicians consider that the informed consent form is just a paper which is needed to be signed by the patient, but everyday clinical practice would show quite differences, many. And so the contrast is between the autonomy of the patient, which is the benefit and the ethical principle we need to follow, with the legal implications of clinical medical practice. And many times the patients will tell us, doctor, I don't need so much information. I just trust you and I go. I remember when I have a kidney operation, I just wait for my urologist to return by, this was on Saturday, when I was diagnosed with stone. And I called him, he was in San Francisco, the meeting, and then I arranged to school with him. And we started giving him all the, oh, don't worry, please. I just choose you, I trust you, go ahead and let me know how we proceed. So many times, the informed consent process, for example, if you have been in touch with some research, the informed consent is absolutely not understandable. So this is the meaning of, do you sign it or do you read it? I would say that 90% of patients will not go through it and they will straightforward sign it. So is it valid, that informed consent? Well, many times the breakdowns in a trustful and trustworthy relationship between patient and physician are resolved in the courts with the malpractice litigation. And this highlights the difference between being competent and being capable. Capable has to do with a lawful decision, lawful regulation. Competence has to do with cognition. And of course, in this cognition, there are 4 components, because they are related to the decision capacity of the patient, the competency, the comprehension and understanding of the disclosed information, and the last one, how do you document all the process of the consent. And listen at some of these numbers. Patient assessed after preoperative consultation show low retention of topics. 70% do not read the form those sign. 73% do not understand the risk of the procedure. 67% recall deficient. They do not remember what has been informed. So it's very difficult to provide sound or valid informed consent. And look at the cognitive abilities. This is a cohort of patients which were assessed by the mini mental state or Folsom test. These are the numbers are impairments in orientation, in data registration, in attention and calculation, 60%. So how the patients are going to understand when you explain numbers, percentage, and risk. Memory impairment is 67%, and impairment in language and comprehension, 12%. So I would say that in many countries, the improvement of health literacy is mandatory. And this is a piece of document which I copy from a book of a text of medical humor. And I would like you to think about the boundaries of the information you need to provide a patient who is undergoing any surgical procedure. This is for a hernia patient, which is a relatively simple and not that complicated procedure, in order always to provide some light at the end of the tunnel. And look at the possible complications which have been documented in this informed consent form. A larger artery may be cut and I may bleed to death. A large vein may be cut and may bleed to death. The definite is the tube from the testicle may be cut. I will then be sterile on that size. Artery or veins to the testicle may be cut with the same result. An opening around chording muscles may be made so tight, same result. A clot may develop in these veins, which will loosen when I get out of bed and hit my lungs, killing me. 7, clot may develop on 1 or 2 legs, which may cripple me, lead to loss of 1 or both legs, go to my lungs, or make my veins no good for life. 8, I may develop a horrible infection that may kill me. 9, the hernia may be recurrent, come back after it has been operated on. 10, I may die from general anesthesia. 11, but I may be paralyzed if spinal anesthesia is used. 12, if ether is used, it could explode inside me. No longer is it used. 13, I may sleep in hospital bathroom. 14, I may be run over going to the hospital. And 15, the hospital may burn down, and of course I will be killed. And look at the signatures. Signature for the patient, the lawyer for the patient, the lawyer for the doctor, the lawyer for the hospital, the lawyer for the anesthesiologist, the mother-in-law, and the notary. So just reflect, which is the extent of the information we need to provide to allow the patients to make a sound and informed consent. Every single complication, every single risk of those who are also with the carry a very low incidence, but are very, very huge and severe. And lastly, some take-home messages for you. The first tip is that the process of obtaining a patient's informed consent should be refined and improved, but never weakened or abandoned. There is an ethical mandate to enhance this process, and it should be understood as such. It's a process. It means that the patient cannot receive the whole burden of information in just one session for about half an hour. He or she will be vulnerable, will be overwhelmed by the information provided, will not be able to make the best decisions on each behalf. We need to improve health literacy. We need to improve trust in the patient-physician relationship. We need to improve communication. And as mentioned, we need to refine the whole process. And we need to improve the registration of documentation of this form. And with this, I'm more than happy to take questions and answers from the audience. And there you have my email. Please write it down, and I will be more than happy to reply to any comment, any question, or whatever consideration you are able to make. With this, I will stop sharing the screen in order to see you if possible. And I move to the, I don't know if there are additional. No, I can go to, oh, there is someone from Ethiopia. Welcome, Dr. Liu. I'm working with the team in a city which is about 400 kilometers from Addis Ababa. The place is Goba, if I'm not mistaken, which is very close, if I'm not mistaken, to the Veil Mountains. I'm in touch with the surgical team there, and I will probably travel there next year. So hope to see you. It will be a pleasure. Let me go to the Q&A. No, there are not still questions. There are, James. Let me know if you have some by the chat.
Oh, looks like we've got one in the chat by Jay Coaster.
Yes. The 3 priorities, Jay Coaster. One is trust. That's of paramount importance. Trust. Second, communication. Third, build up a relationship. That's about, I think that's the three top priorities in order to enhance the informed consent process.
If anyone else has any more questions, please, feel free to post in the Q&A or the chat. We can wait a little bit longer here.
There's no hurry.
I don't know if you see that, Dr. Ferreres, but a follow-up question from Jay Coaster asking, what's the difference between trust and building relationships?
Well, you need to build trust, and trust will enhance the relationship. Once the patient is sitting in front of you in your clinic, you are starting a relationship. At least I would say from the legal point of view, you're starting a contract with the patient. But that's all. And you need to build a relationship. And that one of the foundations of this relationship, it should be grounded on trust. And trust is built upon communication, since trust is the keystone of the, if you have an arch as a curve, the most important piece of stone is what is called the keystone. And that keystone is the one which allows that each middle of the arc does not move and fall down. Well, and that's all about trust. It's all about communication, which is not the same as charisma. I remember very substandard surgeons who were very charismatic. You need to enhance what is called nowadays non-technical skills. And most non-technical skills built around trust and communication.
Excellent. Looks like we've got some questions now in the Q&A. I see 3 of them. The first one is from Natasha.
I go there, Q&A. Good. Informed consent is vital. Thank you for the lecture. However, how does informed consent apply when governments introduce mandatory vaccination? Obviously, I support vaccination. However, it is reasonable to override choice. Well, that's a very good point, Natasha. But you need to make a big difference. You need to make the difference following the principle of beneficence, of the greater good. And many times, the greater good, when confronted to pandemics like the one of COVID-19 or to rubella or to mumps, I would say that there is some requirements from the states which provide, from the point of view that we live in a community, so you need to go with certain common grounds. And many times you need to have some restrictions placed on your own mandatory vaccinations. So, of course, there's the other side of the library, which will support from an ethical point of view the negative to vaccinate physicians, to vaccinate patients. But the idea, the ethical justification of vaccination is that you are providing the greater good and you are protecting the whole society. And when you decide to live in a community, well, you need to follow some guidelines. If you live in an apartment, you are free to do whatever you want, but you cannot shout or put music at high volume after, it depends, maybe 8 p.m., 9 p.m. You have to respect some issues regarding the whole. So you need to care more about the whole than from the individual. Sulafa, the question is the following: how do you suggest we improve teaching communication between doctors and patients in medical school? Oh, well, that's a good point, because I will tell you that in the University of Washington, the Center for Surgical Ethics organized 6 seminars per year to provide communication tools. And this is among, as I mentioned before, the non-technical capacities as described by the Royal College of Surgeons of England. So that's the important thing. It should be improved. It's not usually taught, but it should be taught, it should be learned, and it should be practiced. Efficient and effective communication. Sarah asked, could you please explain difference of competence and capacity once more? Capacity is a legal consideration, it's a legal approach. Competence comes from a medical approach about the cognitive. You may be capable and competent. You may be capable but not competent. And why you are not competent? Because your health literacy level is very low. We see that, for example, in many Latin American countries, in people who get their attention in public state-run hospitals, where you see the most poor people, the most under the level of poverty. So capacity is illegal. You may be capable because you are 18-year-old and you can make decisions upon your body, but maybe you are not competent. You may be capable because you are 48, but due to the impact and the burden of disease, you are not able to make decisions in a clear way to decide what is best for you. So that's the difference between competence and capacity. One is from a legal point of view, and the other from a medical, neurological, and psychiatric point of view. Dr. Liu, are there cases where we take our decision with our consents in a case like on a person unconscious and planning on transfusion, but family will refuse because of religious reasons? Well, I would say that Liu refers to the Jehovah's Witnesses. And here is a big, big difference if you know or you don't know. Usually, I would say that most of those following the precepts of Jehovah's Witnesses carry with them cards, etc., etc. And I would say that if the patient is competent and capable to make his or her own decisions, you need to follow that decision. If the patient is as unconscious, I would say you need to have a proof that he or she are followers of the Jehovah's Witnesses. And usually these people carry with them some card, some ID, which makes very clear, and you need to follow, although they are unconscious. The situations differs when the patient is a minor, because the patria potestatis, which is the parenthood preeminence, the first was in Latin, is taken in that sense from the family or from the relatives to the state. Bandana asked the following. After thanking for the lecture, thank you, Bandana. The question she poses is there any role of a clinical ethicist in the informed consent process? Well, there is definitely a role for a clinical ethicist, but I would say that most of the times, these issues are solved between the patient and the therapeutic surgical group. And of course, these issues, these conflicts arises when a patient is going to be subjected to a surgical procedure. It's quite different, and the requirements are much, much less stringent when you are going to provide just a pill or medication.
Excellent. That seems to be all the questions for the Q&A at the moment, and may be the conclusion of the lecture today. We'll give it maybe another half minute here. Thank you for the great Q&A, everyone, and thank you, Dr. Ferreres, for your response.
It has been a pleasure, and as I repeat, please don't forget that you are able to reach me whenever you like, and I would be more than happy to collaborate with your doubts or concerns. Have a great day, and thank you very much. Bye-bye.
Bye, everyone. Bye, Dr. Ferreres. Thank you very much.
Have a great day, and let's stay in touch.
Yes, absolutely. And to everyone, I would just say next week, our lectures are going to be on medical futility and surgical ethics. So please, you know, if you want to see those lectures live, we'll be featuring them Tuesday and Thursday at the same time. And again, just to reiterate, please, you know, feel free to check out the free cyber patient cases on the platform, work up your skills, and implement some of these surgical ethics skills that we've been learning. Great to see everyone in the chat. Thank you so much, and enjoy the rest of your week and have a great weekend. Bye for now.